And they came back and they said, no, low relative humidity is a driver for higher infection rates.
As a doctor and you're training in the medical field, how did you come to arrive at talking about humidity?
So after I graduated from medical school, did my training, I was practicing as a pediatric oncologist. And my young patients would, often survive their cancer, survive chemotherapy, only to get an infection while they were in the hospital. And these infections are actually like alarmingly common. They're called nosocomial infections or healthcare associated infections. They're a big problem. As a physician, I felt like the building had a role in which patients got infections. It wasn't the whole story, but it seemed to be part of the story. And yet, as a physician, when I tried to, explore this possibility with the facility managers in Boston, they just didn't really want to talk to me, and I didn't understand much about buildings at all. And when I talked to my physician colleagues, they just said, wash your hands, give the correct antibiotics, and don't worry about it. That's all that's involved. But as time went on, I thought about how people do in their physical environment, and more I thought I need to understand buildings. So in the ripe old age of my 40s, I went back to school, got my master's in architecture and engineering, and worked for a while designing hospitals. So I could really talk about buildings, understand mechanical systems. And then as I went back and worked with infection control professionals in the hospital, I sort of had like a eureka moment one day, which was instead of just using these surrogate techniques for evaluating the cleanliness of a room, Petri dishes or different ATPase wipes or the different metrics, I thought, why don't we use the Petri dish, so to speak, in the bed called the patient? Why don't we look at how the patient's doing as a reflection of the building? Once that occurred to me, I thought, well, this is so obvious, it must be what everybody does. We look at human health as a building metric. Mm-hmm. But I've come to find that that's not always what happens. Buildings are usually monitored for energy use or real estate values or
right.
aesthetic value, windows and cool forms, but rarely are building occupant metrics used to reflect on the building, unless you're in a disaster, like whatever it is.
Right.
With that sort of framework in my mind of using patient outcomes to evaluate the hospital building, I found out about a study that was going on up in the Chicago area where a group of researchers were looking at the movement of bacteria and viruses in a hospital building. So they were interested in how the environmental parameters, especially indoor air characteristics, influenced how a building is occupied by microbes. So I found out about that, and I called them and I said, hey, I'd love to look at patient outcomes in the parts of the hospital you're studying. So this very energetic microbiologist was like, sure, awesome. So it sent me a lot of data. So in analyzing that data around patient outcomes, we had about 400 patients and all of their records. We had 11 variables in patient rooms and nursing stations that we were looking at. Mm-hmm. We were looking at carbon dioxide, temperature, hand hygiene, compliance, room traffic, VOCs, HEPA filtration, room air changes, pressurization, all the sort of parameters that are considered in the design of a patient room. So we had about 8 million environmental data points. We sent all of this off to our statistician and said, are there any independent variables? Are there any building characteristics are related to either more or more or fewer infections? So the data came back and our statistician said, yeah, the patient room relative humidity is lower, the infection rate is higher. And I was like, what? I don't even know what relative humidity really was. I mean, I had some idea, but I thought,
what is he talking about?
I thought, that's wrong. Exactly. So what do you do when you get unexpected data? You fire your statistician, which is what we did. So we hired a new group. We said, could you get this right, please? Could you give us something we expect? Right. And they came back and they said, no, low relative humidity is a driver for higher infection rates.